Alright, so we'll be finally starting with the first session. I would like to call upon stage the people who will be chairing the session. Dr. Bansi Sabu, could we please request you to please chair the session? And Dr. Nikhil Nandan, please. Could you please have you to chair the session?
Please just stand, all of you. Join your hands.
May He cause us both to enjoy protection. May we both exert to find out the true meaning of the scriptures. May whatever we study becomes lustrous. May we never quarrel with each other. Thank you.
Good morning, everybody. Now we start the first session with Dr. Navyal Singh, who is going to talk on adult obesity is not comorbidity. Does adolescent obesity have comorbidities? To introduce Dr. Navyal Singh, he is the director of the Naveen Hospital, Hyderabad, Andhra Pradesh, General Secretary, Hyderabad Chapter, AIAARO, and he is the executive member of National Body of AIAARO.
Respected chairpersons, the dignitaries on the dais, my seniors and colleagues. Today we are talking about the comorbidities. We all know comorbidities exist in adults, but comorbidities in pediatric age group is also catching up now. We have been seeing that the adolescent population is growing, and India being one of the countries where we have got a lot of adolescent populations. In this, almost about 20 to 30% of adolescent population in the metros are seen to be having obesity now. And why are we getting this obesity in such a large population? It is because easy access for the foods, lot of availability of high calorie dense foods, and less of exercises, both working parents, and no places for playgrounds and other things. Obesity doesn't start from the elder age group at all. It can start right from the intrauterine life, like the last trimester of the pregnancy. Then we have a weight gain at the early infancy. We have a weight gain at adolescent age. So this has to be controlled right from the early stages of life. How do we control it? Whenever we see a mother or a pregnant woman gaining weight in the pregnancy, we have to rule out the other causes first. And after ruling out the other causes, then you have to look into this and then control it at that stage itself. Second is the infancy period. When the child is born, most of the mothers who are in the metros, they compare their child with a neighboring child or their friend's children. They want their child to be healthy, and healthy doesn't mean in other forms. The healthy means in a weight gain form. And this adds up to their weight, and that increases their obesity. A child who is overweight or obese in the early infancy and late infancy tends to become an obese adult. So that has to be controlled in that period. Then second is during adolescence. Adolescent period is also a very crucial period where the weight gain goes to almost about 10 to 15 kgs they gain weight. So that is the period that again the child has to be controlled. So now, adolescent obesity is almost about 30% in population, and they are at risk of diseases. We cannot afford to have a diseased population at a later age. So Then it is growing. Environmental factors are both working parents, less family meals, TVs, and types of food. The available food which we are having is easy food. You just order with a click of a button, you get the food home. So most of the meals are from outside only. Very few parents in the metros and all, they try to cook their food at home. Then in the schools, again, we don't have any playgrounds. There's no encouragement for any sports or any other things in the schools. They are going more in for the academic purposes. And the social also, too many parties, too many birthday parties. Again, they have got all these cakes, high dense fibers, high calorie foods and all. Then the peer influences. I'm not going to touch much about the genetic and the endocrinal factors because there are so many people who is talking about it. Now, how are we going to identify a child is getting obese? The most important thing is whenever the child is coming for a checkup, he should be plotted on a graph for the weight and the height and compare this height. As soon as we find the child is gaining weight more than his ideal weight, it has to be controlled. Then how are we going to control? We have to educate the parents, we have to educate the teachers, and then see that he is involved into more of activities and all, he is involved into good eating habits, not much of oily, fatty, fried foods, less of TV viewing, less of snacks and other things. So we have to watch for the sensitive periods. What are the sensitive periods? Sensitive periods are again infancy, and then again adipose rebound is there during 5 to 6 years and during the adolescent age group. Then intervention and treatment is going to be a lifestyle change, exercise, nutrition, family motivation, traffic light diet plan. Family motivation is very important here because if suppose you ask a child not to eat a high dense fiber food and other children or other parents and all are eating it, then that's not going to work for us. Then prevention is again, the mothers should be encouraged to have breastfeeds. The babies are encouraged to be having breastfeeds because many children who are not breastfed tend to gain more weight because when the child is taking the breastfeeds, the child takes the required amount of feed. But if suppose the child is on top feeds, then he tends to take more feed than required for him. Second thing is the feeding time is also shorter in those children. Third is these are the children whose satiety level also goes up. So when the child is on the mother's feed, these are the children when they grow older, they stop their food once the stomach is full. But children who are on the top feeds or on the bottle feeds, they tend to continue eating even after the stomach is full. That again causes obesity. TV viewing has to be controlled, and computer, junk foods, positive speeches in the school, education in the schools and the social platforms has to be taken care of. Now, we are concerned more about the problems which obesity is causing in the children now. Previously, we never used to see any cardiac problems, we never used to see any hypertensions, we never used to see much of dyslipidemias in the children. But now, of late, we are seeing the cholesterol levels are rising, triglycerides are rising, HDLs are low, and hypertensions are there. In my own clinic, I have seen number of children who are a little obese, more than almost about 20 to 30% more than their ideal weight. Their blood pressures are on the upper levels only. So these were never seen before at all. Then second thing is pulmonary. We have obstructive sleep apneas. Then asthmas. Asthmas are on the increase. There are other factors of asthma, but obesity is one of the main factors where we are seeing asthmas also. Then gallbladder diseases, where we have NAFLD, that is non-alcoholic fatty liver disease. These are also, here we are just seeing the infiltration of the fat into the liver cells. Then pseudotumor cerebri. Pseudotumor cerebri has been studied in some of the Western countries where they have found children who are obese come with a lot of headaches, blurring of the vision, noises in the ear. It was thought to be most migraine or any other causes, but after ruling out all the causes, it was found the obesity was one of the main causes which was leading to this. And once the weight was controlled, the symptoms have decreased at the early stages. If it is not controlled, then they tend to go in for other complications like blindness or difficulty in academic performances were also affected in such cases. Then endocrinal, type 2 diabetes mellitus, metabolic syndrome, PCOS. Previously, this metabolic syndromes and diabetes was a disease of the old. But we are seeing diabetes as early as 5 years, 6 years of age nowadays. Then orthopedic problems like Blount's disease and slipped capital femoral epiphysis. Blount's disease, normally whenever the child is obese, during the growing period, the medial metaphysis of the tibia overgrows, and this causes bowing of the legs, and then there will be a waddling gait, and in the slip capital femoral epiphysis, they get joint pains and all. We have psychological problems like behavioral problems, anxiety, depression, and low self-esteem with disordered eating, school isolation, poor performances, and bullying by other children too. Now, the most important is about the significance of NAFLD in children. This is a spectrum where we find a lot of status, but the problem here is we cannot go in for higher investigations like liver biopsies and all. The children who were obese were found to have infiltration of fat in the liver cells. If it is not controlled at this stage, then it goes in for hepatitis. Following that, it goes for fibrosis and cirrhosis, which is at a later date, not at the early stages. Then clinical features of this and how they present is, they present with abdominal pain, discomfort, and weakness, fatigue, and jaundice. The only treatment where we investigate and diagnose this is with the liver enzymes or ultrasonography. MRI and CT scan also helps in diagnosing fatty liver disease. This has been seen in 22% of the children, school-going age group, and almost about 50% of the obese children attending the obesity clinics. These are also associated with insulin resistance and cardiovascular diseases, and it causes bone mineral density is low in this, poor mineralization because of the adiposity, the vitamin D deficiency will be there. They will not have enough of bone formation in this age group. Then weight management has been proved to be the only cause and only effective therapy. Treatments like vitamin E, metformin, and pioglitazone has been on the trials, but results are yet to be awaited. So now the take-home message is the obesity has to be controlled right from the early infancy, childhood, and adolescent age group. Good eating habits has to be inculcated in all the children. Playing for almost about 1 hour minimum has to be encouraged in all the children. TV viewing has to be reduced, and family meals has to be encouraged. So these are the things which will help in reducing the comorbidities in the adolescent age group. Thank you.
Thank you very much, sir. I would like to ask Dr. Nikhil Durandar to please kindly hand over the memento to sir. Thank you.
Dr. Uday Phatak is a physician and at Pune, and he is also post held in different part of IMA in Miras, and at present practicing consultant and diabetes specialist. Now I request Dr. Uday Phatak to give a talk on limitation of present therapy.
Good morning. Actually, my speech is on limitations of treatment of metabolic syndrome. There is some reshuffle, so I'll be taking this. As you all know, metabolic syndrome is a syndrome which has got 6 components. There is abdominal obesity, atherogenic dyslipidemia, hypertension, insulin resistance, prothrombotic states, and pro-inflammatory states. This condition has been known. Number of synonyms have been given that are shown here. Metabolic syndrome is going to affect almost 314 million people worldwide. And it affects all the age groups and both sexes. This is common in diabetics. Almost 75% is the incidence of this. Pathology is not fully understood. And clinically, we have obesity, hypertension, and diabetes. The rest of the parameters are biochemical. Definitions are variable, and the adjoining graph shows that there is a rising incidence of metabolic syndrome. It rises from 20 years to 60 years, and then there is some decline. Actually, problem starts with definition. Some people ask the question, is metabolic syndrome a syndrome or a disease? It has been said that a syndrome is a recognizable complex of symptoms or physical and biochemical findings for which direct cause is not understood. The components exist more frequently than would be expected by chance alone. When the causal mechanism is known, the syndrome becomes a disease. So by this definition, metabolic syndrome is just a syndrome and it is not a disease. Etiology is not clear, and what we are treating is we are mainly treating end results of the metabolic syndrome. This is the classification, or these are the different type of guidelines that have been given. And over the period of just 8 years, we have 6 major classifications of definitions. WHO and NCEP guidelines are frequently used. And there is problem in the sense that this study was conducted in Chennai, where V. Mohan and Parikh, they studied few patients, around 2,000 and odd patients, for metabolic syndrome, and they found that with WHO definition, 23.2% were having metabolic syndrome. Then 18.3% with NECP ATP definition, and IDF definition 25.8. Now, if you put all the definitions together, and if you find or analyze, then only 9 to 10% will be having metabolic syndrome. So the problem is, what is the status of those who do not obey all the 3 definitions? That is one thing. And second problem is, males outnumber women if ATP3 is used, or women outnumber IDF by IDF criteria. So which one is correct? So the problem I can mention is, the criteria for the diagnosis of metabolic syndrome are ambiguous. There are a lot of limitations of this definition. The cutoff value is entirely arbitrary. It is not based on the scientific reasoning. It is based on the statistical information. Risk factors of coronary vascular disease like smoking, alcoholism, family history are not considered here. Impaired fasting, impaired glucose tolerance, diabetes, and impaired fasting hypoglycemia are clubbed in one particular condition, where we usually consider diabetes as a coronary equivalent, and we usually, even if there is only one thing, we usually treat that condition. Microalbuminuria, which is the marker of early renal involvement, has not been given so much of importance, and in some definitions, sometimes diabetes is part of the metabolic syndrome, sometimes it is excluded from this definition. And that is how there are a lot of problems in defining metabolic syndrome. And this is actually these are the principles of management of metabolic syndrome. ABCD protocol came in 2008 in Mayo Clinic, and they suggested this. Now, if you look carefully at this, these are the standard guidelines of management, and actually what we practice is we usually control cardiovascular risk factors, we control hypertension, we control cholesterol abnormalities, we control diabetes, and we exercise. And this is true not only for metabolic syndrome, but this is true for any condition for that matter. And really we do not understand what is the difference in metabolic syndrome management and those without metabolic syndrome. Now the next question is insulin resistant syndrome really has a central role in the pathogenesis of this condition really? Now if you look at this, I have shown that there are some treatment modalities here, and actually insulin resistance, when it was treated with different drugs like thiazolidinediones, like rosiglitazone, pioglitazone, troglitazone, problem was biochemically or by hormonal studies, there was reduction in the insulin resistance. However, components did not come down. We require treatment for isolated component, we require treatment for hypertension, we require treatment for hyperglycemia, we require treatment for endothelial dysfunction, and that is how we really do not know if it is the basic cause, then why this doesn't work. And then another controversy in medicine as usual is cardiovascular risk factors and use of aspirin. People are saying that if patient has got metabolic syndrome, ideally one should start aspirin right from beginning, but this is not so. And actually it has been assessed with the help of 10-year, actually it is the Framingham risk score, and accordingly it has been found that if the risk is, say, 10-year risk is more than 6%, particularly with metabolic syndrome, person has to go for aspirin. And that is how it is the risk-benefit ratio should be considered in this situation. And therefore, the treatment with aspirin is mainly individualized treatment, and that should be the discretion of the clinician. Next problem is, are there contraindications for treatment with metabolic syndrome? Suppose we are treating patients with hypertension and we are treating ACE blockers, ARBs, these are supposed to be the best agents for hypertension. But what about beta blockers and diuretics? They are reducing one component of metabolic syndrome, elevating in another component of metabolic syndrome. Or same problem with niacin that reduces hypertriglyceridemia, but sometimes it can produce hyperglycemia. And particularly thiazolidinediones, they are the agents mainly approved for insulin resistance syndrome, but they do not bring down any of the components of metabolic syndrome. So there are a lot of problems associated with this. Now, the next point is, can plasma lipidome explains everything? This is the latest issue that has been presented in New England Journal, and it says that the plasma has maximum amount of lipids in circulation. And with the spectroscopy, it has been found that there are 6 major components beyond HDL, LDL. And these components, there are more than 6 components, 600 components, and they probably have some relation. This is going to be, in near future, probably we'll be having this type of classification, where species 56.4 is going to correlate with body mass index or subcutaneous fat, and that may become an early marker of obesity. Or there may be other parameters which may suggest that patient has got insulin resistance syndrome, or decreased glycerophosphate levels probably will indicate that the patient may turn hypertensive. So controlling lipid metabolism, is it going to be the final treatment for this? That is the issue. And actually this slide shows that you can explain probably all the components, that is steatohepatitis, obesity, insulin resistance, diabetes, hypertriglyceridemia, coronary artery disease, and different components of metabolic syndrome can be controlled very well with the control of this. Now, my last point I would like to highlight here is, if we stratify patients into 2 groups, those with metabolic syndrome and those without metabolic syndrome, then what treatment are we going to offer? Plasminogen activator inhibitor, CRP, they do not require any treatment. And whatever components I have suggested here, diabetes, hypertension, coronary artery disease, atherogenic dyslipidemia, hyperuricemia, obesity, actually treatment is the same, irrespective whether the patient is having metabolic syndrome or without metabolic syndrome. Only difference is in without metabolic syndrome, patient may require 1 or 2 agents, and with metabolic syndrome, patient may require 3 or 4. That's the only difference. So I can conclude that the criteria for the diagnosis of metabolic syndrome are completely ambiguous. The value of diabetes in defining metabolic syndrome is questionable. The validity of using insulin resistance as a unifying etiology is uncertain. There is no clear basis that excludes or includes coronary vascular disease as the risk factors. The CVD risk associated with syndrome appears to be no greater than the sum of its components. Treatment of this syndrome is not different from the treatment of other components, and the medical value of this syndrome appears unclear. I think that is the point I would like to highlight here, and if there is any question, I would like to answer them. Thank you.
Entity or a phenomena is identified in medicine that attracts the attention, particularly when you are thinking of screening communities. And metabolic syndrome has helped as a phenomena to screen communities, not to treat an individual patient. Because in an individual patient, even a low HDL as a single risk factor, cardiovascular factor, you would identify and you would want to do something about it. So that's very different. And one of the definitions, in number of definitions that you gave, is harmonization. And harmonization definition, they have tried to see that something which is peculiar to South Asian and West circumference, that has been identified separately for the Westerners and the rest. Yeah. So I agree partly, and partly I don't agree. Partly I don't agree because I think consider this as a tool. And I also wanted to ask one question to Nonihal, when because of the time restraint you said no. But if we are ever thinking that obesity association has some impact on national health policies, then I think today our schools, which are engaging them from school classes as well as also from extra classes, that they are not left with any time for the recommendations you have given for the exercises and things like that. So what I had done was, in a school health education and enlightened living program that we had from our institute, the trustees of the school, the teachers, the principal, and the PTA, that is parents, were involved. And what we say that if they are studying for 5 hours in the day, where they are sitting down, if they can find out every half an hour, 10 minutes to walk and remember what they have read, so they will revise also, and they'll get that physical activity. And they would not waste time in eating the readily energy kind of food, that would also, because we have seen that in the 10th standard, 12th standard board examination, they put on enormous weight, and particularly young girls come with secondary amenorrhea because of obesity. So if we are taking some action which would be meaningful, I think at a Naunihal, at a level where somebody's ears and terms of the school education, civil or anybody, I think we should do that.
Thank you, Dr. Vaidya. Requesting Dr. Durandar to give a moment of appreciation to Dr. Uday Phatak. Now we move for the third talk. That is to be given by Dr. Abhay Muta. I request Dr. Abhay Muta to come on the stage to give a talk on treatment goals. You are. Some change. There is a Dr. Milind Patwardhan is going to talk on obesity. Okay. So I request Dr. Abhay Muta to give a talk on treatment goals for metabolic syndrome. Abhay Muta is a senior diabetologist practicing since last 20 years in city of Pune, and is a chief diabetologist at Ruby Hall Clinic. Over to Dr. Abhay Muta.
Good morning, everybody. Respected Chair and my fellow delegates. We have heard Dr. Phatak telling us about metabolic syndrome. I have some of the slides which are quite common. I'm just going to run through that. As we just heard, metabolic syndrome is so common for all of us, and we cannot really go away without that when we are practicing diabetes, obesity, or hypertension today, whether you're a physician or you're a surgeon. Basically, there are certain factors which we see every now and then, and they are so mixed with each other. As we rightly heard, that it's very difficult to differentiate patients having these things separately or together. But ultimately, we have to treat, our goals remain very same. And when we're treating metabolic syndrome, or that patient with obesity, with hypertension, with insulin resistance, ultimately the goals for all of us today is to try and tackle that obesity and prevent cardiovascular morbidity and mortality, which we are quite aware of. Basically, this is the term which we all know has been quite revived from time to time, and a lot of new things are coming up. And basically, Rivan, who coined it as Syndrome X, and a lot of names are given to this till today. But ultimately, what we are worried about, all these factors which we all are aware about, and this is something which we need to tackle. And basically, these are the linked abnormalities. When we are deciding our goals to treat metabolic syndrome, it is not only obesity or diabetes or hypertension. All these associated problems needs to be taken into account. As we just heard, we cannot really do much about increased CRP and prothrombotic state, but we should be aware of all this because they definitely come into the treatment part of it. And basically, when we are treating the metabolic syndrome or associated abnormalities, these are the 4 things which need to be tackled very seriously: insulin resistance or diabetes, the atherogenic lipids of the patient, the obesity itself, and basically the blood pressure, and automatically ultimately the problems which tackle. As we just heard, that for every small definition there are debates between IDA, between ADA, between ATP, and there are different guidelines given for their diagnosis. Similarly, for treatment also we have different guidelines. As you can clearly see, there is a lot of debate about even deciding what are the levels of blood pressure, what are the levels of lipids, what will be called to be labeled as obesity, or for that reason for metabolic syndrome and all. So basically, we won't go in all that controversy. We have to tackle all these different things. And as we know, whether we are dealing with metabolic syndrome as a syndrome or different diseases or different problems associated with this, the actual implications what are there are all these which are seen in this slide. And nowadays,